And it is my pleasure to welcome you on behalf of the entire NAMI Board of Directors to our 2023 Annual Education Forum. NAMI's annual educational forums are an essential platform that we use for sharing knowledge and fostering meaningful discussions on issues in our community. This year, we have chosen to look at mental health care for older adults. Our forum's title this year is Mental Health Equity, Bridging the Gap Between Access and Quality Treatment for older adults. Our research shows that mental health inequity is becoming more prevalent among older adults. Unfortunately, many older adults don't seek help when it comes to their mental health wellness because of the stigma that surrounds mental illness, accessibility of care, and the quality of care received. This evening, we have planned a dynamic and informative program that includes a distinguished panel of mental health professionals who have dedicated their professional careers to working with and addressing mental health accessibility and quality of treatment among older adults, particularly older adults living in Prince George's County, Maryland. Our overall goal this evening is to extend senior research outreach and promote an environment where we can address the specific needs of older adults in our community. Our panel discussion will be moderated by NAMI board member Adeza Okonkwo and facilitated by NAMI board member Rhonda Wood. There are a few housekeeping things I want to note at this time. We have included an online survey of tonight's program that we would like for you to complete and return today. You'll be able to access this survey in two ways. There's going to be a link in the chat that should be on the right-hand side, or there'll be an email address that will be provided to you at the conclusion of this program. Again, thank you so much for joining us tonight. And I'll now turn the program over to Wanda, Ms. Wanda Wood.
Good evening, everyone. Thank you so much for joining us today. We are delighted to have you. We are very excited about tonight's program, and we would like to introduce our three panelists that we have with us this evening. Our first panelist that we have, our esteemed panelists are going to be able to provide some amazing education for us related to mental health and providing care, whether you are a caregiver or someone who is supporting someone who has a mental health condition, who is an older adult or of the elderly community. Again, we're excited to have you. So first, I would like to also make sure I introduce the Executive Director for iMind Behavioral Health, Winnie Moore. Winnie, if you can just maybe wave so everyone can acknowledge who you are. You're on.
Yes, this is JB. I'm sorry, I just wanted to break in to say that Winnie Moore will not be able to be with us this evening. However, Stephen Flynn, the Executive Director for iMind, will be with us. Stephen, are you on? He will be joining us shortly. Thank you.
Okay, excellent. Our second panelist, moving right along. It's going to be an amazing program tonight. Our second panelist we have from Luminous Healthcare Group, we have Archana Leon Guerrero. If
yes.
You could, yes, wave so that everyone who's on can know who you are as you start to speak. Thank you so much for being one of our esteemed panelists tonight. We also have joining us, Karen Hill Allen.
Yes. Hello.
So much. So, Ms. Allen is a licensed clinical professional counselor. She's also a board certified leadership coach and life coach, and the author of the book, No Is Not a Four-Letter Word. Again, thank you so much to our esteemed panelists for being with us tonight. We are excited to hear your insight and your input and your wisdom and expertise about tonight's topics. And so at this point, I would like to turn things over to tonight's moderator, our board member, Adeza Okonkwo, who is going to begin to stir the questions that we have for our panelists this evening.
Thank you so much, Dr. Rhonda Woods, for that energetic and warm welcome. Once again, thank you all for joining us, Dr. Guerrera and also Ms. Allen for this discussion. And to kick things off, first to level set, how would you define good mental health? And Dr. Guerrera, I would love for you to kick off this question for us. And once you've concluded, certainly Ms. Allen, I would love to hear your perspective as well.
Mm-hmm. Okay, I'll answer that question. But before I do, I don't know if Dr. Wood mentioned that I am a psychiatrist, which is a medical physician specializing in behavioral health disorders, brain illnesses, have been for about 40 years, have been with Luminous only a few years, but have been around the area quite a bit, and including a member of this very organization, NAMI, including this branch in the past. So it's great to be back, and thank you for this opportunity. And you asked, what is good mental health? That's quite a broad question.
Hence the opening.
Oh my, that's a hard one. So what is good mental health? You know, good mental health is the ability to feel good about where you are, where you're at in life, to be able to approach things with a positive perspective, to be able to be free, or if not free, to be able to manage well any uncomfortable feelings that you may have of sadness or anxiety or other sorts of problems that beset you, be it physical pain, be it emotional pain, but to be able to handle that in a relatively positive manner that will help you move forward rather than backwards or maintain status quo. And so that's a difficult thing. Actually, it sounds simple, but it can be difficult to achieve depending on what kind of challenges somebody faces in those arenas.
Yeah, absolutely. And I think that very much encompasses what we like to term whole person care. Just not only thinking about the mental aspect of it, but as you mentioned, just being able to be, essentially. Ms. Allen, I would love to hear your perspective on what you think is a definition of good mental health.
Okay, I'll give you two, and I certainly agree with Dr. Archana's definition, but I looked at what the World Health Organization's definition was, and it was interesting. Good mental health is when you can cope with the normal stresses of life. You learn and work productively. So that's the WHO's definition. My definition is pretty much what you just mentioned. It encompasses the whole person, the mind, the body, the spirit, and the emotions. So it's making sure that all of those things are working together. They're working in conjunction with one another. You are in a status or state of well-being where you do feel good and you're able to function well within your surroundings.
Yeah, absolutely. And I did want to check to make sure that we had Stephen from iMind on with us.
Yeah, I'm sorry. I don't know how I got logged in as JB Moore. I think the link she had sent me actually just, I don't know, must have been her personal link, but I am Stephen Flynn, and I'm filling in for Winnie Moore, who is iMind's Chief Programs Officer, and she actually had the flu, I believe, and she may have just be under the weather due to all the medicine she's taking, so she will not be able to join us, from my understanding.
Oh, we're sorry to hear that, but we're certainly happy to have you here. And since you will be filling in for her, I would like to direct the question in terms of how you would define good mental health.
Oh, that's a great question. Good mental health, in my opinion, is someone who, I mean, yeah, I think that's such a broad question, and it's really hard to answer. But I definitely think that someone has the right mindset to be mentally happy and in an emotional state where they're sound. I know that sounds very generic, but it's as simple as that. I think, you know, for someone to be mentally stable, I think their you know, their environment and their well-being has to be in a good place, and in order for them to thrive. So yeah, I know it's very short, but that's just as simple as that.
No, certainly. And I think, you know, as we are working with this definition of good mental health, and we think about whose definition and including the whole person care, and also thinking about the environmental factors, I want to maybe broaden it out a little bit, right? So we now know what we are defining as good mental health, but how can we essentially empower older adults to take an active role in maintaining good mental health? In terms of helping them seek the help that they need. So, you know, we've defined what it is. So how can we help older adults pursue that essentially? And Dr. Flynn, Mr. Flynn, given that you are the last one to speak, I do want to direct that to you to answer.
Thank you very much. So that's a great question. So I think the greatest thing we can do to support older adults is making sure that they stay engaged, and they have that cognitive socialization, right? Because I think there was a study done by Harvard, or one of the Ivy League schools a few years ago, and it talked about one of the things that most older adults in America regret not having, and that's enough friends. So I think, you know, when older adults basically, you know, they have children that get older, they move out of the house, essentially may not communicate with them very well, they end up getting depressed. And so they need a support structure in order to enable them to continue that conversation. Just simple conversations with them can go a long way. Just even if it's, you know, even if it's just check-ins, right? And just checking to see how they're doing, what did they have for lunch, just simple little things like that can make a huge difference for their cognitive, happiness, essentially. But yeah, I definitely think that, you know, we can do a lot to support the older adult community by creating an infrastructure, essentially, that it's like a check-in system. If we could just establish something along those lines, it can go a long way with the older adult community.
Yeah, certainly. And working on this concept that you just threw out here, cognitive socialization, Ms. Allen, in your practice and the patients that you do see, how do you incorporate that concept and what you essentially prescribe to them and or empower them to seek out in terms of resources to maintain a good mental health?
Okay, I encourage them to, first of all, say something to their medical doctor, to have a conversation with their medical doctor, because a lot of times they're comfortable with their medical doctor and not so much with other specialists per se. So start the conversation, have the conversation with your medical doctor. And a lot of times they've been with their medical doctor for many years, so they have that connection and that relationship. I would always suggest that, that I encourage seniors to seek help when they need it. So say something to someone, have that conversation with their friends and family members. And I would encourage the family members to do the same as my panel member had just stated. You know, you have that conversation, the family members check in with one another and so on and so forth. But also you have to look at the where they do socialize, where they may socialize. And a lot of times that may be the church. And so it's important for the church, and I know you'll get to this later, but it's important that the church take a stance and speak on it. And so the more that it's talked about, the more it becomes normal, it's normalized. And there's so many great resources, and we'll get into that as well, as far as AARP, what they're doing, and the resources within our own PG County, et cetera. So, yeah.
Yeah, certainly, Miss Allen. And I think, again, it goes back to the perspective of that whole person care, having the community, not just only services are medically related, but also having that support that's there as well. And so, Dr. Guerrera, I do want to ask, in terms of what Miss Allen just discussed about more often suggesting to her clients and her patients to speak to the medical doctors. I'm curious, from your experience, do you find that when you are speaking to patients, they're much more likely to be more open, or do you find that they're more comfortable speaking to, for instance, a family member, given that they may feel that the family member may be able to connect with them on a more personal level?
So, that really varies from person to person. Some people feel much more comfortable sharing their issues, concerns, happinesses, etc., with loved ones. Others feel more comfortable taking that a little step away, perhaps maybe to their primary care physicians. If they have already established relationships with mental health professionals, then usually they feel quite comfortable with them, or otherwise they wouldn't be in an established relationship. But for your general public, it would be more their primary care physicians. And I'm psychiatry, my husband's in primary care, so he well knows. Unfortunately, primary care nowadays, has gone down and down from 40-minute appointments to 30 to 20 to 15. They keep trying to cut it down, and then the poor primary doc has to address every single thing in their whole life, just in that time frame. So it's a little harder and makes it more daunting for patients to also feel they can tell their doctor's rushed, to have the time to speak. But, I wanted to speak a little bit about this engagement business, and engagement is definitely the number one thing that's important for everybody, but particularly older adults, because they start to lose their connections. They're you gave the example, Mr. Flynn, of, families getting older and moving away, children. But aside from that, their peers, their church members, their best friends, their siblings, their parents start dying off. And so, they're grieving the loss of so many loved ones. So connection it means different things. So elderly is a wide age range, it's middle-aged, it's the old. Now we call it the old, people in their 80s and 90s. So really in geriatrics, we have that word, the old. So, because, really the challenges of somebody 60 years old is very different than somebody 80 or 90. So, if your elders are in their 60s, perhaps you got to remember to call them once in a while, or take your kids over, which are their grandkids, etc., or invite them, whenever your kids are having a little school thing or something like that. That's a matter of engagement. As they get into their 70s, 80s, or whatever, maybe they don't drive, maybe their mobility is reduced, so maybe they need some help getting to their other usual outlets, such as church or women's clubs or whatever. They need some help to make sure they get there. After that, they may start losing some sensory inputs, hearing, vision. And then even if they get there, they still feel isolated because they can't hear. So then to be able to remember, if you're at a family gathering, don't seat grandpa with the hearing aid at the end of the table where he can't hear anyone. Put him in the middle. So people have to talk around him good so he can hear, or simple things like that. Or don't choose a restaurant that's very noisy. Go at an earlier time before a lot of people get there. So sometimes people think, oh, I've included my elder, I've socialized I've provided for their connection, but you actually haven't, because they're still isolated within their own sensory deficits, and they're not engaged. So you got to really think about all of these things. It's a lot of work to help somebody stay engaged, and to think about, how their inputs, their sensory inputs, maybe changing their ability to get places. Maybe they can't hear you on the phone when you call, and maybe they pretend they do, so there's so many factors to it all. And many times it meets a little resistance, because, people tend to be very proud sometimes and not want to admit when they need help. So to find time and skill to really think about what our elders need. And those are elders that are lucky enough to have loved ones around to do that for them. Many of them don't. And then, to work hard within our community organizations to really be there as neighbors for our, people around us, shovel the snow for the elderly person next door. Just simple things like that. It really, it takes a village not only to raise a child, but it takes a village to take care of everybody, including our elders.
Thank you so much for that, Dr. Guerrera. And I think, speaking about village, and when we think about older adults, we also tend to think about them engaging in the sense of spirituality and, attending churches and things of that nature. And I know Ms. Allen spoke about that, or at least touched on that very briefly. And my question is now, how does spirituality play a role in mental health and emotional well-being of an older adult? And Ms. Allen, I do want to ping it to you just because you touched on it first. And I certainly do want to get back to you, Dr. Guerrera, because you touched on a lot of concepts, but I wanted to hear what Ms. Allen had to say first. And Mr. Flynn, I didn't forget about you. I am coming back to you as well. But Ms. Allen, do you mind answering that question?
Yes, thank you very much. Yes, spirituality can play a tremendous role as a resource of support for persons. And not to generalize, many of the aged or seniors have learned over the years that God can get them through a specific season in their life or a specific challenge, that He's a mind regulator, and that He is there for them. And so it plays a very important role. And then I want to be specific about spirituality. Biblical spirituality means to be born of God, be changed by the grace of Jesus Christ. So spirituality includes your spiritual practices and your spiritual disciplines, which may include prayer, meditation, chanting, breathing exercises, and ceremonies and rituals. So God is a healer of the mind, the body, the spirit, and emotion. So it's very inclusive. And with my having a master's degree in pastoral counseling, I ask my clients who come to me if they want spirituality integrated into their sessions. And over the past 20 years that I've been practicing, there's only been one person who has said no to that. So it's very, very important to the mental health and the emotional well-being of older adults.
Yeah, absolutely. And I think it's one of the things that people use to stay grounded. And with the concept of incorporating spirituality in your practice, I am curious in the sense of, how do you feel that religious leaders could help in terms of providing resources to older adults that have mental illness, given that, they spend maybe a lot of time within the church community? How can religious leaders be that advocate for them, if you will?
Absolutely. First of all, connect the dots to the Bible. God left us biblical stories to demonstrate for us and inspire us to seek answers to all the situations in life that we could ever imagine. So it's all in the Bible. And a very common book that we go to for looking at persons with depression, anxiety, those kinds of challenges is the Book of Psalms. And David is a writer of the book of Psalms, one writer, and he pours out his heart in a way that clearly depicts him having a hard time mentally. And so I'll give a shout out to my church, Ebenezer AME of Fort Washington, Maryland. My pastors connect the dots biblically and historically with our Black history. So all of that is included in there. But also we have to look at the ministries that a church has. So we have to create ministries and initiatives that embody good mental health. One example that we've done at my church is Ebenezer's Jewels Ministry. It was established way back in 1988 as the Senior Citizens Ministry. I'm glad they changed the name. And at that time when it was created, it was for persons age 55 and over. We changed that to be 65 and older because the 55 is the new 40. So we've changed it to 65 and older. And this ministry is intrinsically involved in the needs of the elders and the old, as Dr. Archana stated. There's also our Comfort and Care Ministry. That's another example. In the past 10 years alone, I've been a facilitator, participating in some of the panel discussions, presentations, et cetera, like these over the last 10 years. And it's all been about mental health. So going back to your questions directly, it's what the pastors preach and teach and how they tie it back. And so that persons can see themselves as others have been shown and depicted having mental health challenges. And also the various ministries in the church has to reflect that as well.
Yeah, thank you, Ms. Allen. I just love that Ebenezer has all of these ministries that are available to older adults to participate in. And Mr. Flynn, while speaking about religious leaders being advocate, and I mind, being a clinical community practice, how do you see iMind connecting and or collaborating with a lot of these religious leaders to help in advocating for good mental health for older adults?
Well, that's a great question. I want to thank Ms. Allen for her response. I think that was very deep and definitely outside of my expertise. So I'm glad she was the one answering that question. But in regards to religious institutions and how they can help support the community, especially the older adult community with regards to mental health, I think first and foremost, iMind has a major task in the county as a crisis provider. And I think, a lot of what I've learned operating in the county for the last 7 years is that it takes a significant amount of collaboration in order to achieve significant results. And so, awareness is something that's always going to be a challenge, whether it's within the religious institutions or it's just getting, the information out there. It's going to be a challenge. I think that there has to be kind of a two-way door where religious institutions would have to be open-minded to learning about, the different programs and institutions there are that could basically provide that mental health support for the individuals of the parish. And so that's one factor. Obviously, another factor would be education. And I think there's a negative stigma with mental health, obviously. Over the years, in the past, mental health was not addressed. And it's just something that's completely shunned upon. And it's taken us to this day where finally there's a lot of mental health movement and awareness and creating the necessary, momentum that's needed to essentially potentially pave the way for potential collaborations with other important, foundation support institutions like religious institutions. Churches are obviously a very important part to mental health because they provide that spiritual element when no one has anyone else to turn to. They turn to God typically. And so, or they turn to their church or they turn to their pastor. And so religious institutions has a huge role to play in this. And I think that they could definitely be a game changer in connecting individuals within their parish to get the necessary help and the appropriate help that they need.
Yeah, I absolutely agree with that, Mr. Flynn. And I think it comes back to what Ms. Allen touched at the very beginning, which is it certainly takes a village. And I think with reducing stigma and of course, advocating for better mental health care for older adults, we certainly need collaboration from all types of institute. And with that, Dr. Guerrera, as we are essentially building this coalition of collaborations, when you think about, the significant shortage of providers, particularly mental health, how do you think in terms of policy, what changes do you think need to be implemented to increase the number of providers? I mean, while we can collaborate with churches, we can collaborate with local clinics, in terms of your practice, what do you think needs to be done to ensure that we also have medically educated physicians to also help in that effort?
So I'll get back to that in a minute, but just wanted to say something about the spiritual aspect as well. We are a diverse community. We are a diverse nation. So I just wanted to point out that spirituality is very important to people of all traditions, not only biblical traditions.
Mhm.
And so, those are important to support and recognize as well. Also, in working with the elderly, so many of them, aside from connection, there's that connection with the afterlife. I'm getting close to death. What does that mean for me? My loved one is getting close to death, or I've lost my loved one through cognitive. They're not dead yet, but it's not my mother anymore. She doesn't know me. So there's a lot of loss that people are dealing with. And so really and truly, and this is not from the medical textbooks, but this is from experience that I can tell you is the biggest comfort to deal with loss that's already happened or loss that is about to happen is spirituality. And people who even maybe hadn't lost touch with spirituality or never been spiritual, many times find it in their later years if they are cognitively intact enough to do that. And that is often the most comforting thing. And the connection that they are still able to have, even if they can't hear or can't walk or can't get to church, that personal relationship. So with whoever their God may be in any tradition, biblical or not. So that's really important. Now, your question about policy, I have been a policymaker in the past, and it's hard. So, regarding getting more physicians into geriatric care, it's really hard because really and truly the populations which are the hardest to treat medically, mental health, are those in which you have large systems to need support, such as children's mental health care, and the elderly. So both pediatric psychiatrists and mental health clinicians, as well as geriatric, are very few and far between. We can't just talk to our client and get the history. And I've always been one for getting collateral history from families on all my patients, regardless of what age. But with the elderly and with children, but also with the elderly especially, it is imperative that you got to do that. So that automatically doubles, triples your time. And unfortunately, none of the payers in medical care want to pay for that time. So it's very hard to find, clinicians willing to do those things. That said, policy-wise, there's a great trend towards something called collaborative care, which sounds fancy, but is really simple, which is to have mental health professionals, trained mental health professionals, work very closely with those primary docs. So I know you've heard me bellyache a few times about how the primary docs don't have time and the mental health docs don't have time either. But if they work together in a very collaborative way, usually within the same clinic, running cases, maybe there's a social worker or some kind of case manager assigned to the whole caseload, say in one primary doc's clinic, to run over everything and then go over it with the mental health professional. You know, Mrs. Smith, I think she might be a little isolated. Mrs. Jones seems to be having an exacerbation of her schizophrenia. Mr. Fitzpatrick just lost his wife, and so just boom, boom, boom. And then, the mental health clinician can just quickly say, oh, let's, send an outreach, oh, do a MOCA, oh, do a this, oh, do a that. And the mental health clinician is not the one who has to do that all, but directs the primary care clinic staff, nurses, physicians, social workers. And so really is able to maybe address 50 patients in the course of a 1 hour run through rather than maybe, 6 visits that day. So it's a very powerful mechanism that is gaining ground. There's a question of who pays for this. So they pay the primary care docs for this. They don't pay the mental health clinicians. So the primary care clinics need to pay the mental health clinicians, and that's so there needs to be a little change in that. You're asking, you might think all I talk about is money, but we're talking about policy, and money is important in policy, right? No one's going to work for free. And so, but people are passionate about this type of work. And if there is a reasonable, sensible payment arrangement that will triage the workload in a manner that utilizes the skills best of the limited clinicians that there are, this is a wonderful model. It's really starting it. I think it's going to, Medicare is really picking up on it, and which is, the main payer for the elderly over 65. And I think this is going to be a sea change in the next 4 or 5 years, hopefully, if we can get our government to do anything.
And if I may, before you move on,
Yes, absolutely.
just add a little bit to the policy side as far as what may be in place and what needs to be in place. A large segment of the older population is on Medicaid and Medicare. A majority of therapists do not take Medicaid, primarily due to the low reimbursement rate. If the policymakers increase the rate for Medicaid and eliminate some of the red tape, maybe that would be a way for our older persons to see clinicians as they need to. A huge drawback has been Medicare. Medicare, as we know, is the largest healthcare program in the country. And according to an article that I recently read in the Explainer, which was March 2023, Medicare has an enrollment of over 258 million U.S. adults. So about 1 in 4 Medicare beneficiaries live with mental illness, but only 40 to 50% receive treatment. Many therapists do not take Medicare due to its many restrictions, including but not limited to persons like myself. LCPCs do not take Medicare due to its restrictions, including not allowing us to service Medicare clients. To the contrary, LCSWs, licensed clinical social workers, can give treatment to persons under Medicare. But the good news is that beginning in January of next year, LCPCs can service Medicare clients. It will expand its coverage of mental health counselors and marriage and family therapists under Medicare Part B. So that's the good news that's on the horizon. And it's estimated that there are about 140,000 LCPCs in the US, and I venture to say it's probably more than that. But that will open up an opportunity for a lot more clients.
Yeah, absolutely. And that's actually awesome that there is a possible or to be implemented expansion in Medicare. I do want to ask Mr. Flynn, are there any, in terms of with iMind, have there been any restrictions with Medicare serving Medicare patients? And you know, has there been, in terms of the restrictions, has there been other solutions that have been implemented to provide care to older adults that are seeking it through your organization?
Wow, I'm really impressed by all of these very detailed questions. No, they're very good. You're definitely on point. Um, where do I start? First and foremost, I will say that Prince George's County has one of the highest Medicaid populations in the state of Maryland, yet has one of the lowest utilization rates in all of Maryland. So there's a problem right there, right? So individuals who qualify to receive services aren't utilizing their benefits to receive services. So that's problem number one. Another problem you have, like Ms. Allen had mentioned, is it Dr. Allen or Miss Allen? It's Miss Allen. Okay. Yeah. So just another problem she did mention, and I just want to echo it slightly, just because it is a very important factor. Historically, LCPCs have been advocating, to Medicare to allow LCPCs to essentially be able to treat individuals with Medicare. That's good news to hear that in January, Part B will allow that. Now, one of the things that I think that, and this goes on to a little bit, this touches a little bit on your previous question before I answer the newest question. And that's because, talking about how to sustain the amount of shortage in the industry. And that's a huge problem because there's not enough clinicians in the field. That's across the country. That's not just Maryland. That's just not Prince George. It's across the country. So we're working on right now. iMind is working on very creative initiatives to try to pilot certain opportunities or try to present from a policy standpoint justification to pilot certain opportunities that allow a pathway to professionalism. And that pathway starts anywhere from becoming a peer support specialist, peer recovery specialist, and guiding that individual along the pathway to essentially earn, potentially they need a degree, obviously, if they don't already have one. But then once they get that particular degree, guiding them, essentially giving them the experience and knowledge and support and training they need to essentially pass their test to become a licensed social worker or a licensed counselor, right? Because I think that if we don't mold that new influx of personnel in the community, we're never going to be able to replenish the massive shortfall that we have from a clinical clinician standpoint. So that's one element, I guess, in regarding your previous question. But I think your most recent question is in terms of how or what is iMind doing to support individuals that may be older and don't necessarily or may have Medicare, for example. So iMind started out as an outpatient provider, and we had a slew of programs when we entered into the sector. We've morphed into becoming, not only do we have outpatient programs, but we morphed into becoming a crisis provider for the county. And a lot of the work that we do is grant funded. Grant funded programs allow us to support individuals that may have Medicare, may have Medicaid, may have private insurance, may have no insurance. And so grant funded programs allow for kind of a non-biased element where we don't have to say, oh, do you have insurance? What type of insurance you have? Let me get authorization from the insurance company before I can treat you, right? As with grant funding, certain type of programmings would be allowed to just treat the individual regardless of their payer source. And so I think there needs to be a lot more of that has to happen in order for us to be able to treat, let's just say LCPCs weren't allowed to have be able to treat patients with Medicare. So you're kind of facing an issue where now you kind of need to figure out a solution. And so it's a combined effort, because grant funding itself can't solve everything.
Yeah.
And so it's a combination of factors. And from a policy standpoint, Dr. Guerrero mentioned that there is some change, and there is change happening with regards to movement with Medicare, but also with private insurance companies. From my understanding, some of the things I'm hearing is that because Medicaid and Medicare are moving towards that direction of funding, more mental health crisis situations and so forth, that insurance companies, in order to do business in the state of Maryland, will have to adapt, and they will have to start, providing coverage for certain mental health conditions. And so I don't know all the details on it yet. It's still all up in the air, but that's the discussions that I know that are happening right now.
Wow, I think that is awesome. And I'm curious to know, in those discussions that are still being solidified, what role is telemedicine playing in that? So we're talking about, there is a low utilization of Medicare older adults. And if they don't know that they can use Medicare to access mental health, how will they also know that telemedicine exists? And I bring this up because when we talk about a bigger concept called social determinants of health, and we think about, gaining access to services, and all the things that encompass gaining those access to services. So we're specifically just zoning in right now on just the access portion of social determinants of health. How can they even get to that portion of it? How are we trying to use technology in a sense? And Mr. Flynn, I want to start with you, and I see Dr. Guerrero has her hands up, so I certainly will ping it to her, but I want to start with you because you spoke about how, most of what your services provide are funded by grants. So sometimes with grants, there are specific requirements in how you use that money. So I'm curious to know, does that allow flexibility to use technology to reach your population?
So I think, I think obviously from a state perspective, they recognize there's a huge clinician shortage, right? And so the one of the challenges that, in general you have is, if a clinician can work at home behind their computer, comfort of their home, working behind their computer, treat the individual, from the comfort of their home, versus going out and doing field work, they're always going to choose to work behind a computer and stay in the comfort of their home. So I think, states and the government, they do recognize that challenge, especially with the amount of shortage. We know during COVID, they allowed telehealth and they allowed these different telehealth, telemedicine functions. Do I foresee any of that going away? I don't necessarily think it will go away. There might be more restrictions or caveats added to it, but I think from a policy standpoint, I think that they're looking at all options right now to consider, how can they support the demand, right? But also provide high level service, right? And so right now there's a lot of discussion, and there's no official kind of verdict on it. But I do see it moving in a positive direction.
Mm-hmm.
And just I guess one further note is that there, I think from a telemedicine standpoint, there are certain limitations. And when I say limitations, I mean individuals need that in-person kind of experience. And we actually, as a industry, need clinicians to really come outside of their comfort zone that they've gotten comfortable with and get back into kind of in the office in order to kind of provide that in-person experience. Because I think it goes a long way with the client, right? I think it can make a much more impactful difference with the client, especially an older adult who's not used to technology. And when you're talking about youth in general, youth, they tend to don't have that same attention span when you're not in front of them. And so, I think from an impact standpoint, in person, there's no comparison. In person is by far superior to telemedicine in terms from an effective treatment standpoint.
I would like to agree as well. But I also would like to think about in terms of, having the older adult get to those appointments, because that's also a barrier for them as well. And Ms. Flynn, I will return to you, but Dr. Guerrera did have her hands up because she wanted to touch on telemedicine. So Dr. Guerrera, please.
Yeah. So I've been involved with telemedicine for about 30 years. And 30 years ago, it was quite, obviously in its infancy. It was making progress slowly but surely, very slowly, both in terms of technological improvements that made it possible, as well as regulations that limited its use. And it clearly had promise way back then to improve access as it did now. The COVID, if any one good thing came out of COVID, it was that sea change within a few days that transitioned the country into be able to do telemedicine. Telemedicine has really improved access of care for so many people in so many specialties, especially mental health and substance abuse, particularly in rural areas, large states where people, to access somebody in person, even if clinicians exist, they have to drive an hour or two just to get to that appointment. That takes a lot of time. So, or public transportation in big cities, many changes, et cetera, even if they have transportation modes. So it has really improved things. And while, it is true, most clinicians and policymakers do feel that in person is better, the studies actually show that that is not true for certain populations. For young adults, mental health care by telemedicine actually gives better outcomes than in person. That's with depression and anxiety, not serious mental illness, So we can't just generalize. We got to think of who are our populations and what treatment modality is better for that population. For children, yes, in person is definitely better. And for the elderly, I was working in the nursing homes in the middle of COVID, where people were dying right and left. And you cannot do telemedicine with geriatric people. It's very difficult because they don't know how to work the technology. And even if you have the nurses and all that, they're doing it for them. Many times it scares them. There's a person talking to me out of a screen. What is that? And it can make paranoia worse and all that. So it just, now maybe when people our age, and I'm 60, so maybe when I'm 80, that won't scare me. But the current 80-year-olds, the telemedicine just is not going to work. It does not work for them unless they have somebody there to facilitate. So, as a whole, we do need to get back, but it certainly does improve access. So in an area where an elderly person maybe doesn't have access to get to the appointment, but if they have somebody younger there with them that's able to facilitate the technology and reassure them that this is just your doctor, and if that's a hybrid model, hybrid is really ideal, where they do meet the clinician in person sometimes and tele other times. So they at least have had some human contact with that person live. Then that studies do show that hybrid models work better than pure tele for all age groups.
Wow, interesting.
Before we move on, I have some good news to share on that as well. I'll be the bearer of good news.
Sure.
So many states are under consideration for what is called the Counseling Compact Agreement, which enables licensed professional counselors who practice and reside within member states to practice without the need to obtain multiple licenses. For example, I'm licensed in the state of Maryland. For me to see a client in DC under the Counseling Compact Agreement, I would be able to do so as long as DC is a member state. And so right now there are 28 states participating, and Maryland is supposed to be decided upon in January. So that's the Counseling Compact Agreement. So just as telehealth has been a tremendous bridge during this COVID period in which we live in, this is going to be great as well, especially for those persons in rural areas.
Yeah, absolutely. And I think, you know, part of when we discuss about telemedicine and then the barrier to use in terms of knowing how to use the technology, you know, when we also think about what you just touched about, Ms. Allen, about those are in rural areas, you're also thinking about, you know, access to internet, period. Does that
Yeah.
exist?
Yeah.
So, you know, essentially there are multiple barriers, but I do wonder, what in a perfect world, what would we suggest in terms of reducing that barrier? Because while, you know, there is a case of, you know, we're dealing with access in terms of, do you even know how to use a computer or a phone? Do you even have access to an internet? In a perfect world, what would we say we could implement to reduce that barrier so that we can then reach a larger population? Because, you know, when we think about the older adults, there is an issue of mobility there. And that is a huge consideration when we are trying to provide care to the older adult population. So Ms. Allen, and then Mr. Flynn, I do want to come back to you to answer that question, because I did start off with you and I wanted to also get back to you as well. But Ms. Allen.
Well, simply those persons that have been accustomed to conducting the telehealth sessions, we have to get out there and go and see the clients in person. I don't do that as a LCPC, but I know that that typically falls under the umbrella for social workers, where they were doing the home visits once upon a time. So it's getting back to that. We've become very comfortable and somewhat complacent with the telehealth, but I totally agree that there's nothing like that in-person session. As a matter of fact, I myself am thinking about beginning in January that I am not going to see persons via telehealth. It's only going to be in person. That's my personal preference. So you have to get back out there, get from beyond the computer and get back out there and do the home visits.
Mm. And so your suggestion would then be meeting the patient where they are then, if that is the suggestion.
Absolutely, because the old persons and those with disabilities, et cetera, it's a hardship for them.
Yeah,
And
absolutely.
not only that, I'm sorry, you get so much more information when you see them in their home environment.
Yes.
Are they able to keep it clean? Are they able to do their laundry? You know, you can see it. Is it strewn about? Is there cat litter everywhere? Does it smell of urine and feces? You know, you learn so much more about them than if they come to your office, because they might pull themselves together for that, but that doesn't mean that's how they live. So you really learn so much more about all their activities of daily living if you go to them.
Yeah, absolutely. And Mr. Flynn, in a perfect world, you know, you didn't have all these barriers to telemedicine, and maybe you're practicing in a hybrid model. What would you think is the best solution, or one of several solutions to reducing that barrier to access?
So that's interesting. It's a concept that we've thought of. It's a concept that we have implemented. And so one of the challenges that was mentioned is, you know, earlier with regards to telemedicine or telehealth is people are afraid of it. People don't know how to use it. People don't know how to log in. People don't know how to use a computer. People don't know how to use a tablet, whatever it may be. And especially with older adults, because this is a huge learning curve for them. So one of the things that I think that, you know, if especially from a policy side, if you know, getting access to individuals who may not be able to access services is a priority for the government, a simple solution would be to utilize peer support specialists more. And so the way that I look at it is you can utilize a whole new, or you can create a whole new service. And that service is essentially using peer support specialists as facilitators. And they would basically have a caseload of individuals in which they collaborate with clinicians and psychiatrists and medical personnel, essentially, but their primary objective would be to go out there with their smart device and facilitate these sessions, so you can say, with the clinician. I think that if there's structure for that type of element, and I mean, like I said, from a mass perspective, but I think that is definitely one way to solve the telemedicine kind of restrictions there are, and improve, I guess, you know, the amount of people that turn out and make those appointments.
Yeah, absolutely. Having so-called of a buddy system, as I like to put it. And, you know, while we're thinking about all these innovative initiatives, so we're speaking about the collaborative care, the expansion of Medicare, perhaps, you know, implementing or, you know, practicing in a hybrid model. I'm curious to hear from the panel what other emerging research findings or treatments or modalities have you come across that hold promise for improving mental health for older adults? And Dr. Guerrera, I would love for you to kick us off with this question.
Well, you know, so this is not so much service delivery, but treatment modalities. I'm sure you've heard about newer treatments for Alzheimer's that could possibly arrest its development from early stages. That may be kind of overcalling in terms of what's been recently approved, but the research is happening. And so, you know, as of now with dementia, when Alzheimer's or Lewy body dementias, which are the two most common type of dementias, are diagnosed, they've actually been present in the brain for probably at least 30 years before that. So yes, I mean, they're neurodegenerative disorders, and they start in the 30s and 40s, before any of us even know about it. And so if there can be screenings at early ages, just like we have, you know, our mammograms, our PSAs, our things that we look for from an early age for health condition, you know, our blood pressure checks, all those things, to be able to treat things at an early point. That's what we need to do for the dementias as well. Again, right now, when we recognize them, they are in their late phases. There is no treatment for them. Zero. The medications we give might slow the decline a little, but that's all they do. It's going to decline. It's going to get worse. The brain has already degenerated a lot by the time we diagnose it. So if we can catch those early, imagine how wonderful that would be. And that research is ongoing. And that is a huge game changer.
Yeah.
Not only for dementias, but other neurodegenerative disorders as part of that. Parkinson's, glaucoma is a neurodegenerative disorder of the optic nerve. So there's a lot going on in terms of the brain and nerve preservation.
Yeah, that's interesting. And certainly, I think we can all agree preventive care and medicine is much more effective than late stage and trying to save someone. Ms. Allen, I would love to hear from you if there are any other initiatives that are emerging that you'd like to share.
Not that I am aware of. I just have to remain hopeful. And doing so, you know, I think I'm in a better position to help my clients remain hopeful as well. So I just remain hopeful. I just remain hopeful. So I don't have anything additive to that.
Yeah, and hope will certainly see us through. Mr. Allen, I'd love to hear from you what your thoughts are on that as well.
Mr. Flynn.
Oh, I'm so sorry. Mr. Flynn. I'm looking at you, Miss Allen, and I'm looking at Mr. Mr. Flynn.
So, yeah, I don't have much more to add to this, but what I could say is that I know that socialization it plays a major role in the mental well-being of an individual, whether younger, older, it doesn't matter. It has great effects, and maybe even greater effects than we truly understand. And so, you know, that would just be my 2 cents on it. I think that if we can, you know, find a way, whether that's doing social events or getting, you know, just having older adults be cared for. I mean, at the end of the day, they just want someone to talk to, and we want to reduce depression, right? I mean, I think that's one of the biggest kind of elements that you see in older adults is you see severe depression. And, you know, from at least our perspective. And so I think that that's just one of the holistic ways that I guess could address it in a way that's helpful.
Absolutely. And we are getting close to the end of our discussion session. I am saddened that I'll have to close things up because this has been very riveting for me, and I hope it's been the same for you as well. But just to close us out, I mean, we have certainly been speaking on a very heavy topic, and, you know, I always love to end on a positive note. You know, if you had one word, just one, that you could share with folks in terms of caring for an adult, older adult that has mental illness, what would you say? What's that one word that you would give them? The word of wisdom, if you will. Mr. Flynn.
One word.
You can make it two. You can make it two as well if you can't fit it into one.
it would have to be love, right? I mean, I think love heals all. Yeah, love is the one word that comes to mind.
Miss Allen.
Since he took my word,
Mine too.
I will say, have faith. Have faith.
Absolutely. And last but not least, Dr. Guerrera.
Love was my word also, so I will also change it to empathy. Empathy.
That's a very good one.
And
Yes.
can I just describe that a little more?
Yes, of
The
course.
ability to step out of my shoes into your shoes, and then back into my own shoes to act accordingly.
Yeah, absolutely.
Mhm.
Yes. I would love to thank you all so much for joining us for this panel's discussion. And with that, I'd like to turn things over to JB, Serena. Turn things over to Serena to give us some closeout messages.
Then we'll go to Rhonda for the Q&A section.
Oh, it's Rhonda. Okay, I'm so sorry about that.
Thanks. Wonderful and wonderful. Thanks. Rhonda will facilitate the Q&A section.
Okay, wow. Man, let me tell you, the 2023 Annual Education Forum for Mental Health Equity for Older Adults, this has been a phenomenal evening. Amazing evening filled with insights, perspectives, and shared experiences. I want to first and foremost give a thanks to our exceptional panelists who graced us with their wisdom and their expertise. It was amazing. I took tons of notes. I learned so much. I appreciate your dedication and your commitment to mental health equity, particularly for older adults. It's truly commendable. And the things that you shared tonight, I'm sure, are things that will have resonated with a lot of people and will help a lot of people who have these types of experiences. So my huge thanks to Dr. Guerra. I appreciate the insights that you shared. Thank you, Ms. Karen Allen, and thank you very much, Mr. Stephen Flynn. We appreciate you being with us this evening. Also a big shout out to everybody who joined us tonight, because your presence and engagement was truly appreciative as well. So as we wrap up, we want to make sure that the conversation doesn't end here. So in addition to the insights that were shared tonight, we also want to emphasize the importance of your voice. Your thoughts, questions, and feedback, they matter. So we are going to invite each participant on this Zoom call to take a few minutes to fill out our survey. It's a very short survey, and it's critical. Your input will help us, NAMI Prince George's County, it will help us to refine our future events, the offerings that we give for our education forums. It will also ensure that what we are offering meets your needs and your expectations. So the survey link will be shared shortly in the chat. And if everyone could take a moment to complete that, we would truly appreciate, one, your time, but also your honesty in providing feedback. And there it is, it's in the chat. If you check the chat, it's from NAMI Prince George's County, and there is the link. So again, we appreciate your feedback. It will help us tremendously to serve you better. So if we could just take a few minutes to do that. We just want to make sure that we can continue to carry this torch of mental health advocacy forward. Want to make sure these discussions don't stop here. Like I said, I learned a lot. I appreciate the discussions about not just the things where we had the challenges, areas where we need to do some improvement, but I also appreciate the upcoming policies and initiatives that are happening. I had no idea. So I found those things very informative. And of course, I appreciate the part about spirituality. I found that part really enlightening, and just realizing the importance that plays for the community of older adults. So thank you again, everyone, for being a part of this transformative evening. Let's make sure we stay connected. If everyone can take a moment to make sure they complete that survey, that would be awesome. And I will go ahead and make sure everyone knows that the link is in the chat. If you just check your meeting chat, you'll see the link.
Are we taking any questions?
Oh, yes, sorry. Just wanted to make sure we took the moment to do the chat. I think the survey is only a couple of questions. So hopefully people have got that up and hopefully started submitting that. So while we are completing the survey, or if you've already completed the survey, we would definitely like to open up the floor for questions. And so we can acknowledge you if you want to either raise your virtual hand or raise your physical hand. We can take you off mute, or if you feel more comfortable staying off camera, you can feel free to type your question in the chat. So any questions for our esteemed panelists? Oh, okay. We have to change the permissions on the survey. Okay, we're working on that. So while we are working on the survey, we will take any questions. Okay. We are getting nothing but lots of kudos. Everyone has loved, I mean, some of the feedback, great evening, great discussion, awesome panel discussion, excellent, bravo. Very inspirational group, nice discussion, great, well-informed discussion. This was great, excellent panel, informative insights. Kudos and gratitude to the Prince George's County Health Department, local Behavioral Health Authority for supporting NAMI Prince George's County's work to reach out to older adults and those who serve them.
And yes, Rhonda, I think we have a question by Eunice Harrison.
Okay.
Harrison, yes, I do.
Oh, okay. All right.
Hi.
Sorry.
Thank
Hi.
you so much. Can you hear me?
Yes, ma'am. Yes.
Thank you. This was absolutely wonderful. I have a sister who's maybe in the early stages of mental decline. I mean, she might be sort of not admitting it, but yeah, there are signs. I wouldn't call it dementia at this point, more memory loss at this point. But aside from the medical doctor, what resource would you suggest that I might avail myself of for mental services? If I had to have an entry point for that, aside from a primary doctor, does NAMI provide that kind of service, or just what would I do if I needed to go beyond the primary doctor?
Can I answer that? So, I am here representing Luminous Health today, which
Okay.
has new behavioral health services at Doctors Community Hospital in Lanham. New, when I
Right, I'm
say
familiar with
new,
that.
within the past year or two. And
Mhm.
so they have, full spectrum interdisciplinary team of mental health clinicians there. I don't have the phone number, but it's at Doctors Behavioral Health. I don't work at that location, but I did lay eyes on it just yesterday. And
Okay.
so, yeah, they do have outpatient care, so you could probably call there and seek services. If your sister is willing to go in, sometimes that's a little bit of a
Right,
problem
and
too
that's
as
the
well.
thing. She can be a bit obstinate at times, so. But I could just call and maybe get an appointment, or should I just show up? You say they have an outpatient, so
No,
that would require.
don't just show up. Definitely make an appointment. Yeah.
A call. Okay.
Yeah, there's
So-
always
Thank you.
walk-in, there are walk-in services, I'm not familiar anymore with the crisis team in Prince George's County, but I'm sure there is a crisis team through the Core Services Agency.
Okay.
Yeah,
So, Ms. Harrison, I'll just add to that. So, one of the
Mhm.
things that I think that you could seek is when you see get an appointment with a mental health clinician, is to seek a diagnostic assessment. And so, what typically a clinician will do when they're getting familiar with the patient, is they have to conduct a diagnostic assessment, and that will allow them to establish a baseline and then go with recommended treatments and so forth after the diagnostic assessment is completed. So that's kind of like maybe step one. But as Dr. Guerrero had mentioned, Luminous has services. They have outpatient services. They have an urgent care. iMind as well, and there's a slew of different providers, but iMind specifically also has a mental health urgent care. So if it's an emergency situation, no appointments necessary. You could just walk in and get treatment the days that the mental health urgent care is open. And again, with Dr. Guerrero had mentioned that there's a mobile crisis team, which is more referred to as the mobile response team for Prince George's County. So iMind is the mobile response team provider for Prince George's County. And so anytime there's a crisis situation that's a mental health related emergency, the purpose of the mobile response team is to alleviate unnecessary hospitalizations and unnecessary incarcerations. So, when it's a mental health emergency, that's where we dispatch a team of clinicians and peer support specialists that will arrive at the scene. And so some of the times we're being called by law enforcement to respond. Some of the times we're getting, calls from 988, or we're getting direct calls from the community. And so if it's a crisis related situation, the mobile response team will dispatch 24/7 to the location of the crisis. And there's two ways just to reach us. One is you could call 988, or three ways to reach us. You can call 988 and ask to be transferred to the mobile response team. You can call 911 and ask to be transferred to the mobile response team, or you can call the mobile response team directly, and I can put that number in the chat. But it's a season number that's been known in the county for over 20 years.
Oh, that was very helpful. And in terms of the mental health clinician, would that be the person at Luminous Health that I would go to? Are they considered mental health clinicians?
So mental health clinicians
To
come
get the
in.
diagnostic he was
They're-
talking
Yeah,
about.
the diagnostics somebody would be assigned to do an intake, also known as diagnostic assessment. Whether it would
Okay.
be, what type of clinician it would be may depend on who's available, but if whoever that person is feels that someone of another discipline is important to be involved, then they will make sure that happens as well.
Okay. Thank you so much.
You're welcome.
I'm going to open it up to see if anyone else has a question for our Q&A session. Feel free to either raise your virtual hand or your physical hand and try to scan to see if anyone else has a question. And then also, if you feel more comfortable, if you want to stay off camera, feel free to put your question in the chat. We have.
Can I ask a question?
Absolutely.
I just wanted to ask because I wasn't able to get on. I had a meeting, but I saw that this meeting was recorded. Is the recording going to be submitted to the participants afterwards later so that I can review the meeting?
I believe the answer is yes. Yes.
Okay. Okay, great. Thank you.
Very welcome. Oh, so the link to our survey is back active. So if we can put a fresh link in the chat. Yes, so we have the link back up. If everyone could take a moment to click on the link. Again, it's critical for you to provide your feedback and honest comments for us so we can be able to, NAMI Prince George's County can be able to serve you better. So the link is in the chat. It is active. If you click on it, it'll take you to the form feedback. A few questions. Take a few moments to do that. In the meantime, if anyone has any last burning questions, you can raise your virtual hand or your physical hand as I scan, or you can put your question in the chat. I think we had Deborah Bennett. Feel free to take yourself off mute and ask your question or your comment. Deborah, you're on mute. Did you put something in the chat? Maybe put something in the chat. Did you want to ask a question or do you want me to read your chat? I can't tell.
Oh, yes, I apologize. I'm using my phone. It's a little technical challenge.
Yes.
Yes, I wanted to mention, I heard some of the panelists talk about innovative methods in terms of addressing mental health needs. And I heard the discussion about using peer support specialists, certified peer support specialists as a buddy system. And I am definitely a supporter of that because NAMI's basic tenet is, peers. I would also suggest consider family peer support specialists, certified family peer support specialists as another resource. And I share that because I serve in that capacity, helping family members to navigate services, sharing with them lessons that I've learned. And oftentimes they reach out in times of crisis. And so I'm suggesting that because while the family member has a need, so does, while the individual, the loved one, so does the family member. And oftentimes family members are overwhelmed in terms of what to do, how to help their loved one. So quite frankly, they, don't know what to do. They throw their hands up. And so I'm just offering this as a suggestion because SAMHSA does recognize family peer support specialists. There are competencies that have been vetted, things of that nature. The lack of using them may be because it's not a billable service, but there could certainly be advocacy on behalf of that, because I do believe that peers, that works. And in fact, MCF and a nonprofit in Baltimore City have a pilot where they actually have family peer support specialists who engage when there's a crisis situation. The family member is engaging with the family member of the loved one who's in crisis. So I just wanted to share that, as plant that seed, and so that there be more thinking in terms of how do we help the family members who are often the caregivers. So if I don't take my hand down, it's because I'm struggling right now from the phone.
Thank you
That's
so
good to know. That was great. Good to know. Yeah.
Yes. Thank you, Deborah. We appreciate you and your offering that tip. That was awesome. And so as we as our program kind of comes to an end, I'd like to turn it over now to our president of NAMI Prince George's County Board of Directors, Serena Eckwood.
Yes, thank you, everyone. Ladies and gentlemen, as we draw the curtains on this evening, we are filled with a deep sense of gratitude for all who joined us in the NAMI Prince George's County Education Forum, dedicated to mental health equity for older adults. As Rhonda said, I'm Serena Eckwood. I serve as board president. First and foremost, we want to express a heartfelt thanks to Luminous Health Group and iMind Behavior Health, our distinguished panelists, Dr. Guerrero, Stephen Flynn, and Karen Allen, who graciously shared their expertise and insights, shedding a light on this critical issue. Your contributions have been invaluable, and we deeply appreciate your dedication to improving the lives of older adults. We also extend a appreciation to everyone who attended today, both near and far, who took the time to join us in this endeavor. At NAMI Prince George's County, our mission is clear and resolute: to provide support, education, and advocacy for individuals and families affected by mental health conditions. This forum stands as a tangible part of our mission, a platform to educate and discuss a step forward in breaking down the barriers to mental health equity for older adults. Please be sure to complete your program survey. The link should be in the chat box. But our mission doesn't stop here. It's a continuous journey, as we invite you all to join us in advocacy efforts, whether it's through becoming a member, volunteering your time, or amplifying the message of mental health equity. A link will also be included in the chat box that will give you some information about joining NAMI, the NAMI family. And to our current members and new members, we encourage you to attend our upcoming members meeting, which will be held virtually on November the 15th at 7 o'clock. The meeting will provide you with the opportunity to hear updates on our mission work. You can share your voice and connect with like-minded individuals who are passionate about mental health advocacy. A link for registration for this meeting is also found in the chat box. Let us remember that change is possible when we unite for a purpose and determination. The discussion doesn't end tonight. It carries forward in our actions, our advocacy, and our commitment to making mental health equity a reality. Thanks again for joining us, and I hope you have a good night. Thank you.
Thank you.
Thank you.
Thank you.